imagine that a patient body says, when I'm walking up and down stairs, when I'm sitting, when I'm standing up from sitting, it hurts my knee. When I'm driving on, say, the left with a clutch, it doesn't particularly like it. Come and have a stand just for a second. Like for instance, Bonnie might say to me, when I've got dumbbells and I'm squatting, it's all about the technique at the end of the day as well. So if you just squat a little bit, that'll do. Okay, I'm back up. We'll come on to the technique a bit later. So when you bend again, so my patient says, okay, she gets pain around that angle. Doesn't matter whether it's 30, 40, 50 degrees. She has pain around the front. Now come back off up. Okay. Now if I was to put pressure going medially across, now bend the knee, and she says to me it feels a lot easier. Yeah, then I know that my goal will be to try to get the knee to go medially. Yeah, yeah. So she's bending, and she says it hurts. Back off that position. I push medially, bend down, and she says it feels a lot easier. And maybe part of the treatment will be just to control the patella position, around there. But I might show you a little technique now with the tape, because it does work for lots of people. When you are squatting, how should you squat? The knee should go towards the second toe, and it should not go past the level of the toes, because she's usually past. Yeah, so you can easily see how you get knee pain if a knee might go too far forward. When you're bending, if a knee has a tendency to go inwards, it might be indicative when you're squatting of a weakness in what? Glute maximus when you're bending. Yeah. So glute maximus eccentrically, because glute maximus when you're bending will control the position of the hip and the knee and the ankle when you're bending. Yeah, so if the glute max is weak, then you might notice the knees are going to go in. If you're stepping on the leg and you weight bear and the knee goes in, you've got medial drift when you step. Yeah, when you're stepping on the leg, when you're walking, the knee seems to go inwards a little bit. Or you stand on one leg, you're like wobbly, that's probably a G med. Yeah, so glute med, when you step, will cause the leg to turn inwards. And then look at the alignment of the knee. Yeah, maybe a glute med weakness could cause overpronation of the foot. Okay, so that's a school of thought. Yeah, so when you step in, why might the foot be pronated? Because the glute med can't control the position of the hip, so it allows it to turn inwards. Pop yourself up. So that might be a patella test I could do, is that test, bending, pushing the knee across. Standard patella testing. Look how much movement you have in that patella, okay, within that trochlear groove there. Yeah, it's relatively normal, so you can go side to side. This is just general mobility as you read. Yeah, like so. You can do what they call like a scoop test, where you're trying to agitate the medial side and the lateral side, so you're almost scooping it. Yeah, we're trying to agitate it there, and you can scoop it up and down. You'll notice, if I was to move a patella towards me, there's a ridge there. See that bony ridge? Yeah. That ridge there is part of the lateral femoral condyle, and it's normally higher on the lateral side, and it is why? Where the Indian elephant is located, here. Yeah, you can't really see it, so it's hidden. Yeah, whereas this is the larger side. Can you see it's higher? The side here. Yeah, and it is why? What do you think? Stop the kneecap.
Rotate.
Not so much rotating. Stop the kneecap.
It's like biting the
Popping
nose.
out. Yeah, so you have a higher lateral femcondyle ridge there. You have to stop the patella, because the patella, 90% of the time, will only go laterally. Yeah, and it tends to be more women. Yeah, because of the Q angle and things like that. So, so it tends to pop out. Yeah, that sort of thing. So if she says she felt the knee come out and go in, yeah, and you were to do the apprehension test, so you can do general mobility, you can do a scoop test, you can do an apprehension test, just literally fingers on, and just quickly press medially, like so, and then she'll be apprehensive, hence the name apprehension test. You can do a grind test. All these tests are just looking for patella femoral pain syndrome. Yeah, that's what you're looking for. But there's a test called the Clark test. I suggest you never ever do it. I've seen it done lots of times, and since they've done it, the patients had pain ever since we've done the test. The idea behind it is vice grip, lock in, and then if I lock the patella and I said to my patient, contract the quads, where's the patella going to go if it can't go into my hand? Well, it's got to go down, isn't it? Yeah, and I've seen cartilaginous tears by people doing the Clark's test. Okay, so they do that, and they say tense, and it goes down, and the idea is this is a provocative test for patella femoral pain syndrome. I suggest you don't do the Clark test. I write it down, I mention it, but I suggest you don't do it. Yeah, if you want to do something similar, put your finger lightly, watch now, tense a quad, watch where it goes. Can you see it goes up? Can you see how quick she tense the quads? That's what people do wrong in some ways. They tense quickly. When they tense quickly, you force it down. Basically, I've seen people scream, yeah, in pain. When I've seen therapists do this, slowly tense. Okay, you'll already feel something. Okay, you're already, yeah, relax. Okay, and then now, and then slowly again, be careful. Okay, it's not very nice though. Alright, that's okay. Yeah. Okay, but if you did it quick, she won't like it. And I could probably damage, and she'll have knee pain forever. Yeah, by just doing a test. So don't do it. Yeah, so do I do any of these tests in reality? Probably not. I just say to my patient, bend. Does it hurt? Yes. Yeah. Let's follow patella for moral pain. Tensor quad. Remember, this muscle atrophies very quickly around there. So if that muscle's not doing that much, then the kneecap will try to shift over. So if you want to get this muscle back but you've got pain, you have to take away the pain. Icing works, but you might have to tape the knee. If you're walking downstairs and it hurts every time you're walking, the VM will not work ever. Yeah, so you have to take away the pain. And one way of doing it is by using a simple bit of tape. Okay, so this is the fixer mole of a micropore, actually called something else, it's a knee fix. Yeah, so you got a bit of this, and then you've got the leukotape or leukotape P. This is actually called the Tiger Tan tape from Physique. Together about a pack of about £8, something like that, maybe a bit less, a bit more. What you're going to do with the two white strips, so you're just going to roughly go from the medial to lateral side. That's one. Yeah. So you're not going to have time to do this, but I just wanted to show you a Mconnell taping from the knee, because it's very easy. This should be split. Yeah. Like so. So don't do anything. Like so.
Don't need to round the edge of them.
No, not this. On the K tip you will, yeah, but this one you will not. So from there, I'm just going to angle it on. Like so. Just going to find an arm on it anyway, but I just want to find the centre of the patella, which is probably just where the crossover anyway. So from there, I'm just adapting my technique to this. People struggle ripping the tape anyway. Okay, so from there, literally, the first technique is to tilt the patella. So you just literally just tilting it. So you're just causing a tilt. So you just tilt it down, like so. Thing is, you wouldn't have a brown tip on the skin, so you'd have a white tip a bit more. So the white tip is protecting the skin from the brown tip. That's what it's trying to do. Then this one's slightly longer from the lateral side. Okay, so from there, thumb and finger on the patella, push it medially, and then lock it into position there. Yeah, and then you normally find like you've got a crease on the inside there. And then from there, I'd say to my patient, yeah, try stairs, up and down stairs. So if it'll be limited in movement, yeah, because the tape will stretch a little bit there. Yeah, but I'd be, and she says, yeah, so when she comes in, she either says, yes, it's loads better, or no, it's not. And then I might do a fine tuning with this tape. What I mean by that? If I notice the patella is rotated, let's say for instance the patella is rotated this way, yeah, then I use the tape and I rotate it around. Yeah, I'm going to do that. Or I do it the other way. If I feel it needs to go further, I push it across more, or if I pull it back and lock it down. Yeah, so I just do 3 or 4 variations on that, and then once I've done that, I then put 2 white tips on that, and I leave it on for probably a couple of days. All right? So that'd be a Mconnell type of taping technique. Yeah, for patellar maltracking. Okay, so quite easy to do.